Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a man of 48 years of age without classic cardiovascular risk factors or any background of interest. He arrives at our unit with the diagnosis of STEMI of approximately an hour and a half of evolution. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it. In this electrocardiogram, we have the next alterations. First, elevation of the ST segment on anterior septal leads from V1 to V3. Second, elevation of the ST segment on AVR and high lateral leads, 1 and AVL. And third, mirror image descent of the ST segment on inferior leads, 2, 3, and ABF, and in low lateral leads, V5 and V6. This tells us that we have an acute myocardial lesion of subepicardial or transmural characteristics on the anterior septal region of the left ventricle. This translates to an anterior septal and high lateral STEMI. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, right coronary artery is open and it does not present any significant lesions. Let's take a look at the left coronary tree. As you know, the left coronary tree bifurcates into two different arteries, the anterior descending artery and the circumflex artery. In this perspective, we can see that the circumflex artery has excellent flow and is free of lesions, while the anterior descending artery is cut off. Can you see it? There! Just after the first septal branch. This tells us that a complete obstruction of the anterior descending artery exists, and so the contrast is not able to fill the distal blood vessel bed. This should not surprise us, because the closure of the anterior descending artery was expectable due to the electrocardiogram disturbances previously described, which correspond to the ST segment elevation on anterior leads V1, V2, and V3. Now that we know where the obstruction is, treating it is the only thing left. First, we will have to pass an angioplasty guide wire through the closure. Sometimes passing the guide wire partially opens the artery and allows us to see the distal bed. However, this is not the case. Because of this motive, it can be helpful to introduce a thromboaspiration catheter with the intention of extracting part of the thrombotic content. In this way, a partial unblocking of the artery is achieved, which allows the identification of the extension of the problem. As you can see, the localization of the anterior descending blockage was proximal according to the origin of the first diagonal, which corresponds with the electrocardiogram alterations previously described, which are the elevation of the ST segment on high lateral leads 1 and AVL. It could result contradictory at first glance that the first septal branch was open despite electrocardiogram alterations suggested a compromise of it. We are talking about the ST elevation on V1 and AVR. However, there is no contradiction, because if you look carefully, there is a blocked septal branch. Did you see it? Yes, the second branch. Despite not being the first one, this second septal branch could have a bigger extension. Anyway, the relevance of this point is to ensure flow of the main branch, and implanting a stent in the blockage zone could be necessary. This props the artery and restores blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!